Chapter 32, Health Assessment of Children. In this chapter, we're going to demonstrate understanding of a health history from the child, the parent, primary caregiver. We're going to individualize elements depending on the age of the child of the health history. We're going to discuss some important concepts related to health assessments. We're going to perform a health assessment using approaches that relate to age and developmental of child. We're going to talk about that. We're going to demonstrate the sequence of exam. We're going to talk about normal variations in the physical exam. And then we're not going to go into the sexual maturity of females and males at this time. There's your Pima outcomes. Okay, so we're talking about health assessment. Health assessment of kids or any type of assessment is not quite the same as doing an assessment on an adult. When we talk about children's health assessments, you have to really think about their developmental age and their chronological age, but their developmental age is important because we need to know how to address them. One of the first things I do when I'm going to assess a child is I observe that parent-child interaction. I want to see how they are communicating. I want to see if the child looks scared of the parent or is, attached to the parent. You just kind of want to do an overall assessment of the situation. I'll tell you a little story about a patient who came in, and it was, I think the patient was a toddler at the time, and the mother and father came in. The child had stopped breathing at home. And so they were doing CPR en route to the hospital. The paramedics got him into the pediatric trauma resuscitation room, and everybody was working on him. Mother and father had arrived, so the social worker walked them back. We'll talk a little bit about family presence at code situations. Everybody was doing their best to get this child breathing again. And I was in charge that day, so I was assessing the other patients while the nurse was in there and all the other people, the team. And my first assessment when I was walking up to the situation just to see, how it was doing, if they needed help, was that the mom was sitting in the chair and she was quite upset, crying, sobbing. And the father was playing, I remember, so it's been a while, Angry Birds on his phone. Well, that should send up a red flag. Now, sometimes the fathers in situations are more stoic, but that's just a total disconnect from what's going on. I overheard the social worker telling them, what was going on. They had got a pulse back. They were putting him on a ventilator. He would probably go to ICU, all the sequence of events that were going to happen. And the father's comment was, it's okay because he's a twin and we have another one at home. So that is not a good situation. Social work was following up with that, and I'm sure DCS was putting in the home at that point. So those interactions are important. Obviously, they're not all like that. When you're evaluating kids, whether it's indirectly or directly, you're watching them, you're looking at them. One of the duties of being in charge of the pediatric ER is to go out to the waiting room to assess patients out there, just an overall assessment every hour. And that's what you're doing. You're looking. We call it an across the room look. So I'm looking to see if I have toddlers in the waiting room, I expect them to be running around, climbing on things, getting into things. But to see a lethargic toddler is concerning to me. That's someone who needs to come back. So you're just always observing. And the best time to find out what kids can do is at times when they're not thinking that you're observing them. So they come in and they won't move their arm, take some toys in. If it's okay that they can eat or drink, hand them a popsicle. So sometimes they don't fake things as much as adults may, but you can kind of assess things as you're going along. And when they're in a relaxed situation, they're more likely to come forth with information. The history, we're going to talk a little bit about that, your physical assessment. And then just, like I said, adjusting the assessment to the age of the child. So you're going to establish a rapport. That's the biggest thing. Sit down on the bed, bring some bubbles, bring some stickers, something. Get on their eye level. Talk to them. What's your name? Where do you go to school? Who's your teacher? Do you have a dog or cat? Anything you can do to relate to kids, you'll earn their trust. Same with the parent too. Again, it's how you approach the parent or the caregiver, how you listen to their story of what's going on. So that listening is really hard for us sometimes because we want to do. Empathy, don't promise them anything, and provide that feedback of what's going on. So you're going to do a systematic head to toe, except if a baby is sleeping in the parent's arms or breastfeeding the mom's arms, you're going to leave that kid where it's at, and you're going to get what you can while you can. So listen to the heart sounds, get your respirations, get your heart rate, listen to lungs, listen to the belly. Because once you remove that child from the parent, they're going to be screaming, and it's going to be hard to hear all that kind of stuff. So you do want to go ahead and get the vital signs and things like that. Chief complaint. So why are they there? I remember a doctor years ago went into a patient's room, and she was sort of a regular in the ER, and she was an old crusty lady, just mean and nasty. And he said, what brings you here today? And she said, the cab. So you have to be specific in what you ask, but we want to know what went on. It's really important to know the events leading to it. When we talk later about emergency situations, when an ambulance is bringing in a patient, no matter what's going on, but especially in cases of code arrest or respiratory arrest or things like that, it's really important to hear that story that they got from the parents, that they heard when they were picking the patient up and what they did. So you will see when we go in the hospital, is it a situation like that? When the ambulance comes into the room, everybody is quiet because we need to hear what happened and the story, and then what they did on the way in. Same thing when the patient comes in with a parent. You want to say, so when did these symptoms begin? Sometimes people in the medical field can be very judgmental. Kids come in with fevers, parents don't medicate them for many reasons. So we have to really be careful how we say things and on our body language too. So what I like to say is, what did you do for this? Or did you do anything for this? Like say the kid comes in with a fever. What did you do at home so I don't repeat any of your work? So that's a nice way of saying, did you give anything at home? I think it's nicer than saying, well, what did you give them at home? So we want to be a team. We want to fix this kid together. So you want to find out what happened. It's good to know, does a child have any chronic illnesses? Because there's some conditions, cardiac conditions, where the patient's, it's a congenital problem for kids, and they mix their oxygenated and deoxygenated blood, and so their oxygen level is naturally a little bit lower. And so you would freak out if you didn't know there was a history of that. Again, what did they do, especially for a chronic kid? What's different? Don't use the word normal because there is no normal, but what's different about today? If they come in and say, well, they've had leg pain for a week, what's different today that brings you to the ER? So you're not accusing them of anything because we don't want to be accusatory. Our job is to take care of patients. So if patients don't come, we don't have jobs. But you really want to get to what's going on. Inquiry about exposure to infection. Sorry, it cut off the end. Especially in today's world, but even before COVID was a problem, we would want to know, the mom brings them in and says, these kids in school had measles. Well, I'm going to want to use my proper isolation for that kid. In the wintertime, we have cases of what's called RSV, which is respiratory syncytial virus. It's a bronchiolitis for infants. It's a virus, but it lives on surfaces like your uniform for up to 12 hours. So if they come in with a cough or a cold, I'm going to go ahead and put them on contact isolation because it lives on surfaces longer than the air. Growth and development, we're going to talk a little bit about that. I'm not going to go over how to do a physical exam because you guys know how to do that. There's nothing really different about kids. Okay, growth and development, we want to know have they lost weight? Have they gained weight? Are they acting okay? You know, is this how they act normally? Are they really tired? Sometimes we see behavioral changes. So parents will say, you know what, they're just not acting themselves. Sometimes in the teenager, adolescent age, you know, they became very moody. How do you know what's normal and what's not? They were doing well in school and you know, they're not doing so well. So things like that. Skin, again, we're going to look for rashes. Rashes, when we go over the communicable diseases, rashes are contagious. And so there's scabies and there's lice and there's things like that. So we want to make sure that before we're examining skin that we have gloves on. We're going to, some of this is the same as adults. Do your head check, your eyes and vision, ears and nose, mouth and teeth and throat. If they come with some type of cough or upper respiratory infection, I really want to look at the throat. The younger they are, the more tissue they have in there. And if there's any swelling, it can cause airway compromise. Cardiovascular, kids typically don't have any heart problems unless they're born with a congenital problem. And that's when you get into that history and physical. Respiratory wise, again, chance of putting them on some type of isolation. GI system, we're really concerned with the amount of diarrhea and wet diapers kids have. Infants, anybody who's not potty trained, we want to know, is this a decrease in their number of diapers? Because that's how we would ask, have they have a decrease in urination? And then how about diarrhea? If an infant develops nausea, vomiting, diarrhea, so like a gastrointestinal illness, they can become severely hypovolemic, and that can lead to death. So we really want to be aware of that. Parents know how many diapers they change, believe me, and so you'll ask those questions. And then also, you could have GI symptoms, but we'll be okay. Kids, like I said, a couple poops, a couple vomits, and they could be already volume depleted. And with hypovolemia, you have to address that right away. I'll go over some of the signs later. So GU system, again, the toilet, urine colors, and then musculoskeletal, if that's a problem, and then the rest of your systems. One of the biggest things, most kids who are admitted to the hospital come in through the ER. And so in the ER, it's a very different type of nursing. It's assessments, excuse me. We do focused assessments. So if your child comes in with foot pain, I'm not going to do a head-to-toe exam on him. We're going to worry about the foot. So different places where you work. Now you worked in PICU, in the pediatric ICU, you're going to be doing detailed assessments of every body system every 4 hours at least. So again, it depends on where you're going to be working. So approaching kids. So we talked a little bit about you have to be aware of their developmental age and how you're going to address them. On page 1164, there's a chart on some considerations for examinations. So just it goes through all the stages. I like to keep the kid on the lap when they get, as long as they're not in that school age, or even so. If they're on the parent's lap, just leave them there. You can do your assessment there. And then, like I said, you need to think about what is their developmental age. Are they scared? What are they scared of? Bring some, like I said, stickers go a long way. Put stickers in your pocket. Talk to them about cartoons, things like that. You really need to get on their level to get them to trust you. So for the newborns and infants, like I said, get what you get when you can. You want to make sure that if they're asleep, you want to leave them there. And then you always want to do head to toe, except in those cases, you're going to get what you can. And then also delay the painful procedures for last, or invasive procedures like looking in the throat, things like that. Always leave the caregiver in there. Let them hold. Let them don't make them hold their child when you're doing any kind of procedure like an IV or something like that. But you can involve them in what's going on. So newborns and infants, let them hold the baby. Like I said, listen to everything while it's quiet. The babies are so small that if you're listening to the lungs and they're screaming, it's going to be hard. Or if you're listening to the lungs, sometimes you can hear bowel sounds, you can hear heart sounds because everything is so compact. Count the heart rate and respiratory rate. You can do that before undressing the baby. And then when you think about doing vital signs, you want to make sure that you are counting the respiratory rate. And then also for the heart rate, you want to make sure that you listen to apically. Your book says for children under 10, you should auscultate the apical pulse because it's harder to hear the radial pulse or feel a radial pulse. In older children, you can feel the radial, but you want to listen for at least a minute, especially the younger they are because they can have irregular heartbeats, which is normal, and you want to make sure that you're getting the actual rate. So head to toe assessment, again, unless they're sleeping or you're in the ER. So vital signs in a newborn and infant, their heart rate is very high. So a range is about 80 to 150. Anything lower than 80, I'm going to start CPR on if I've confirmed that it's truly an 80. You think about us, we're 80, we're fine. What if our heart rate was 10? We're not going to be doing real well when our heart rate's 10. And we'll go over some of the specifics with this when we do our skills. Respiratory rate should be 25 to 55. So in a situation where a patient's coding and we're using a ambu bag to get them breathing again, and I'll show you those, we have to go at least 25, because if we go any lower, then they're not getting enough oxygen and respiratory effort. So toddler and preschooler, so your toddler, you want to incorporate some type of play. Remember that they like to play. They really like to, like I said, toys, stickers, bubbles. Bubbles are always good because that kind of distracts them. They like to take their clothing off one piece at a time so you can let them put them back on. They're sometimes watching your face. So remember, poker face. Show them what you're going to use, not the needle, but show them what you're going to use. Let them hold it. Give them a lot of praise. It's not going to work for you to tell a toddler, oh, the little kid next door did really well with this. They don't care because they're egocentrical. So it's not going to help with that. Heart rates, now you can see they're coming down. Heart rate's coming down, 70 to 120. Respirations are about 20 to 30. I don't make you remember blood pressures, but wherever you work, you'll have some type of chart that is acceptable ranges. And blood pressures start off really low and then go up. So it's kind of the opposite. The preschooler, remember, they fear body invasion. They're magical thinkers. They think if they cut themselves that all their blood's going to come out. Or if they have, say they have appendicitis, have to go to the operating room, they think they're going to cut them open and all their, everything inside is going to come out. So we have to be careful. They like to play games. And then make sure that you're addressing pain on everybody. Initiative leads to cooperation. Give them jobs. Remember I talked about giving them jobs. Now heart rate's coming down a little bit, 65 to 110, and rests are coming to more than normal age, a little closer to the adult respiratory rate. School age, once you get to the school age, they're more concrete thinkers. They can understand a lot, but you have to still make sure you're not using medical jargon. So really important to make your words match your intentions. Privacy, especially privacy, school age, and the adolescent. Give them respect. They will, if you treat them like like anybody else, they will typically respect you too. We want to make sure that we're only exposing limited areas, giving them, like I said, a lot of privacy. This is just a picture of their brain. Some other things, when you're measuring vital signs, you want to make sure that you're using the preferred methods of your institution. When you're measuring temperatures, there's several different kinds. There's tympanic, there's temporal, oral, axillary, and rectal. Never use a glass thermometer. I haven't seen one of those since the 80s, but whatever your facility, what your policies, just follow your policies. The problem with tympanic temperature readings that we use a lot in the hospitals, it really depends on the person doing it, because it's a special technique, and if you don't do it right, you're not going to get an accurate temperature. Oral is highly reliable if they can hold it in their mouth. Some kids just can't hold a thermometer in their mouth, but and axillary, you can use axillary. They do that in the newborn nursery, you'll notice. But it's typically, it's going to read a little bit lower, so you have to make sure of that. You understand that. Let's see. Rectal temperature. So years and years and years, they said rectal was a core temperature. It is invasive. Parents don't like it. Kids don't like it. They used to do it when kids were born, and now they don't do that anymore because we have the more modern methods. So always avoid the rectal route if the patient is immunocompromised or has diarrhea, a bleeding disorder, history of some rectal surgery. You just avoid that route completely. Most hospitals will avoid that route 100%, but in areas of infants with fevers under 2 to 3 months old, they will do a rectal temperature. So, because they're concerned about sepsis. Another time that we would not do a rectal temperature is if the patient is a safe baby. And what a safe baby is there's places around town that if you don't want your baby, you can take, no questions asked. Fire departments, hospitals, things like that. And those babies, because we don't know the health history, we would never do a temperature check on that. If you are ever working and then somebody, brings their baby and says, I don't want it, you can try to get some information from them, but legally they don't have to say anything. And it's a service that started, I don't know how many years ago, but it avoids people just leaving their kids, abandoning them, things like that. So we get to the heart rate we talked about, to count it for at least a minute. Same with respiratory rate. You want to make sure that you are actually counting that rate. Oxygen saturation. So there's many places that you can put the probe. For the infants, we put it around the foot. And if there are some that go on the forehead. Kids, when you put them on their fingers, they like to peel them off because they don't like them there. Never put the probe on an arm that has a blood pressure cuff on, or on the finger of the arm that has a blood pressure cuff, or an IV though. Let's see. One of the things with kids you have to be really careful is when you put that pulse oximeter on, wait a couple seconds or minute, because the heart rate has to match what the pulse ox is picking up, and the pulse ox takes a few minutes or a minute. If you just stick it on and it's not catching the heart rate adequately, it'll read very low. And so you don't want to panic and run and find the doctor and call a code and blah, blah, blah. you want to make sure it matches the heart rate. And if you want to know how it is, just take a pulse and make sure. When you put it on the monitor, you'll see what they call pleth, and then you can see the heart rate and it's matching. So then you can take that blood pressure. Accurate size cuff is really important for kids. Same with if you have a really old, thin lady, you don't need to use a regular cuff on. Or if you have somebody that's larger, you have to use a larger cuff. So your cuff size matters because you can get erroneous blood pressures if you don't use the right size cuff. On your book on the page 1172, there's some places that you can put the blood pressure cuff. Because in the adult, we think we just put it on the brachial artery. That's what you learn in nursing school. In kids, we will use the popliteal artery, so we'll put it around their thigh, or you can put it around their lower leg, so it's the posterior tibial or their dorsalis pedis. So we put them in various places. The biggest thing with kids is you have to hold it there because they're going to rip it off, and they don't like it. So pain assessment. So I think we'll go over pain assessment another chapter too, but pain is the 5th vital sign. And we use the FLAC score, and I'll show that to you for the smaller infants. Let's see if there's anything else I want to tell you. Head circumference, we measure. Your book says until 6 years old. If they have any problems like a microcephaly or macrocephaly, so they have large or small heads. But otherwise, up till 3 years old, because their skull will be 90% of an adult's. Let's see what else I want to tell you. When you're looking at the skin, you'll see some variations. So there's something called acrocyanosis. It's normal for babies if they're just a couple days old. Doris will talk more about that. So it's blueness of the hands and feet. Pallor. So pallor is just a pale. Central cyanosis is going to be around the blue. It's blue around the lips, tongue, oral area, and that is a ominous sign. There's certain signs that are ominous, which means bad. So that's an ominous sign. Jaundice. You'll learn a little more about jaundice when you are talking in OB. One of the other things is lanugo, which is some soft downy hair, and that's usually in the smaller infants, and I believe Doris goes over that too. Let's see. When we talk about the head, we talk about fontanelles. So fontanelles are openings of the skull, and beneath that is the brain. So we'll talk a little more of that in our skills on how to assess those. The anterior fontanelle is open longer to about 9 to 18 months. It's normal. And posterior is smaller. So fontanelles can tell us things about the kids. If they are depressed, that's a sign that they're dehydrated. So we do fontanelle checks, and I'll go over that in skills. If they are bulging, then that could be a tumor or increased intracranial pressure. So it's one of those quick assessments. You just run your hand over the child's head and you can tell. Larger fontanelles usually are related to Down syndrome or some kind of congenital hypothyroidism. Okay, let me see what else I want to tell you. Breathing, we'll go over more of this in the respiratory chapter, but infants up to 3 to 6 months are obligatory nose breathers. So if they have boogers in their nose, they can't breathe. So suctioning the mouth is not going to help. You have to suction the nose. Let's see. That's it. The younger the child, the more responsive the heart rate is to activity changes. Also, we see kids with high heart rates when they have a fever. That's going to increase their heart rate. When they're dehydrated, it'll be high. Certain medications, like asthma medications, will make it high. So we have to be aware of that and make sure that we're addressing all of the issues and all the vital signs. Let's see. And then when you're doing your neurological assessment, your developmental screening tools are important in that section too. Okay.